Good afternoon, everyone. I hope I am audible. You can hear me properly. I am Dr. Nandu, Assistant Professor and Coordinator of Division of Policy and Governance here at DYPU School of Public Health, DY Patil deemed to be University, uh, Navi Mumbai. So, on behalf of DYPU School of Public Health, I warmly welcome you to the opening session of our webinar series titled Policy in Action, Ideas, Institutions, and Impact. So, before we begin, I would like to inform you that we will be recording this session and the recording will be made available in our website. So let me begin by briefly introducing the context in which this webinar is being organized. DY Patil, deemed to be university, is a multidisciplinary institution committed to academic excellence, innovation, and public engagement. Within it, DYPU School of Public Health stand as a dedicated center for education, research, and leadership in public health practice. So the school is led by our founding dean, Professor Suma Nair, whose vision and guidance continue to strengthen our academic programs and institutional collaborations. So in our school, we have 4 academic divisions: Division of Policy and Population Health, Division of Health Systems, Division of Environment and Sustainability, and the Division of Policy and Governance. So under these divisions, we offer range of programs, including Bachelor of Public Health, Master of Public Health, Integrated MPH program, Executive MPH in hybrid mode, PhD in Public Health, BSc in Environment and Sustainability, and of course, Master of Public Policy. So our Master of Public Policy program offers 2 specializations, one health policy and the other specialization is climate change and environmental sustainability. This webinar series is part of our effort to strengthen the academic foundation of our Division of Policy and Governance, also to connect the classroom learnings with the realities and policy practice. This series, titled Policy in Action, Ideas, Institution, and Impact, is designed to bring together experts from policy, academia, and civil society to reflect on how policy is being shaped, implemented, and experienced on the ground. So we are delighted to open this series with a session focused on one of the most influential policy document in public health, that is the National Health Policy 2017. So our central question for today is, what has 8 years of this policy meant in practice? To lead us through this critical discussion, we are deeply honored to have with us Professor T. Sundaraman. Professor Sundaraman is a well-known figure in Indian public health whose contribution spans over 4 decades across academia, public policy, and civil society movements. His professional journey began with an MBBS and MD in internal medicine from Madras University, followed by 22 years on the faculty at JIPMER, Puducherry, where he served as professor of internal medicine until 2002. From there, he moved into the health system space, first as founding director of the State Health Resource Center, Chhattisgarh, and then as the executive director of the National Health System Resource Center from 2007 to 2014. In these roles, his contribution significantly to the design and implementation of National Rural Health Mission and helped conceptualize and operationalize India's community health worker mission, community health worker programs, which include the Mithanin program in Chhattisgarh, which was the earlier kind of a version of the ASHA initiative, which rolled out throughout the country later. So from 2014 to 2019, he returned to academia. He was teaching public health at Jawaharlal Nehru University and serving as a professor and dean of the School of Health System Studies at TISS Mumbai. He continues to engage in research and mentoring as adjunct faculty at JIPMER's International School of Public Health while serving on multiple national and international research committees. His scholarly contributions include a significant body of research publication and books. In 2021, as a recognition of his contribution, he was awarded the K.N. Rao Memorial Oration in the annual conference of the Indian People's Health Association. A lifelong activist, Professor Sundaraman is also a founding member of the All India People's Science Network and the Jan Swasti Abhiyan, and recently completed a term as Global Coordinator of the People's Health Movement. It is a tremendous honor to have him with us today for his talk, The National Health Policy 2017, 8 years later. Before we begin, I would like to inform you that you can post your questions in the chat box, and during the discussion time, we can discuss those questions. With that, I invite Professor T. Sundaraman to begin the session. Dear Professor Sundaraman, over to you. I think you have a PowerPoint presentation to share with us.
So I will move to the PowerPoint, and thank you very much for this invitation. It's an honor to be invited to speak on this topic. This topic is rather close to me because I did a lot of the backroom drafting, as you would say, of the policy. Policies are made by government, so it's the government's policy, but I was very closely associated, a member of the steering committee of the policy. And I think it's important to look back on this. And when you are starting this whole series of policy in action, is a very good place to start, because very often many people don't know exactly what policy says. And it's important to know it even when some parts of it are not followed. Yeah. So I think there's one very interesting thing when I teach generally how policy is made and how it plays out, is that the articulated policy is not really the de facto policy. So there is a de jure policy, a policy that is formally adopted, and there is a policy as implemented. And the difference is there are lines in the policy that really get amplified, and everybody relates the policy to those lines. And there are other lines, perhaps when it was written equally important, which get attenuated. You never hear about them again. And at some point, therefore, it is always good to check back not only on what is implemented, but what is not implemented. To many students, they sometimes don't see the effort that goes in and the seriousness of what policy represents, even when it is not implemented. And my single message to you, as somebody who has been engaged in it for now 3 decades, is that actually people there take it far more seriously than we think. And if they don't implement part of it, that is also because there is a certain rationale on that. So I will move to the thing. The national health policy can be best understood with a little bit on the context, process, and the need. So it comes to power, the new government, after a long period, 2 rules of the Congress government, UPA government comes to power in June 2014. And one of its election manifesto promises is a new policy and health assurance, a national health assurance program, as they call it. And there is a number of committees set up. In fact, 2 committees function in parallel to this or are wound up before this, which are also working on national health plans. And then the first steering committee is convened in 8th October. I'm not a member of the committee then. And a dialogue is initiated with the state, subcommittees are formed, they report, planning commission. Then there is a second steering committee, by which time I'm on board. And then there is a discussion within the senior officers, governments, departments, and the draft is put up on December 31st, 2014. So the policy is adopted almost, as you can see, 2.5 years later. And in the period January to April of 2015, the first 3 months after it is put up, there's intensive discussion. More than 5,000 people sent in comments. All those comments are collated by a team in the department, the Bureau of Planning within the ministry. And then there is a whole process of stakeholder consultations. People like the Federation of Indian Chamber of Commerce hire senior IAS officers to represent their views. Industry represents their views. Civil society represents their view. EPW, Economic and Political Weekly, runs a series of 10 articles on the draft policy. And the point only I'm making is that actually the policy took a long, and then it got stuck. It seemed as if it will never come through. And then after a long back and forth between National Health Authority and the ministry and various departments, finally it did get released. And when we were almost giving up hope, we'll see it came through. And quite to your surprise, almost every line on it was detailed, discussed with different stakeholders on that. And it's therefore an interesting thing that if there are certain things that are completely missed in the policy, it's not because they forgot. It's because there was a conscious decision taken not to touch that area because that we could have a consensus on that. So therefore, the point I'm trying to say is that we need to actually engage with this. Now, there was a situation that the policy came in. First, the Millennium Development Goals period, 2000 to 2015, was coming to an end. Mind you, January 1st, 2015, this thing starts. There is also, meanwhile, a huge growth in the healthcare industry. There's a 15% compounded annual growth rate in this period. It is an entirely different situation. There is also, and this is where public pressure comes in, a growing impoverishment due to the cost of healthcare. And finally, because of economic growth overall, the government's budgets are more buoyant. They have an ability to actually spend more on health in a way it was not possible below. And then, of course, there is a political will and a need for a political change. Globally, the Sustainable Development Goals is almost finalized by January 2015, though formally adopted in May 2015, 2 years before the policy is adopted. And the policy has to be aligned to make sure that it is aligned to our international commitments. So we have international obligations and the declarations that we have signed on to, and the national health policy is an expression of this. And therefore, there is all these contexts in which policy is made. The scope of policy is to inform, clarify, strengthen, and prioritize the role of governments in shaping health systems in all its dimensions. I just mentioned this so that one should understand what is a policy. Policy is a government document. A policy has a jurisdictional area. For this, it is the Indian nation. It has already, there is a government in action, it has policies, but it gives a certain guidance on that. And it gives the guidance across 10 areas. So there are areas where it does not go into much detail. For example, in medical education, it touched upon it. But there are other areas or regulation of the private sector, it did mention it, but touched upon it. But broadly, these are the areas that it really covers. The goal, and this goal statement is important. In fact, if you, a very good, interesting study will be to cover the draft document that is available and see what changed in the 2 years, because these were important changes. I have put different colors to highlight the different sources of how this goal is articulated. The highest possible level of health is a WHO declaration, right? It's there. And the well-being is implicit in it. At all ages, this is departing from Millennium Development Goal and its priority to below 5 age groups. And maternal and pregnancy of all, as different from of pregnant women and children, at all ages becomes an important point to make. And this is in line with the exact wording that the Sustainable Development Goals use for target number 3. So that's an act of showing that we are aligned to that. Through preventive and promotive healthcare orientation in all development policies. So that pays respect to the health in all policies and universal access to good quality healthcare services, which is an important criteria and very important coming up into a prominent in the era of universal health coverage is to reduce financial hardship as a consequence. So you can see this compressed goal statement sets out the key reference points for policy. And objectives is an interesting tweak. It says provided through the public health sector with focus on quality. So part of the big discussions why it took 2.5 years to pass the policy was an internal discussion on the scope of the public health sector versus the booming private sector and what they would mean for policy and the commitment to universal health coverage. So, and that this is all reflected in the language. The language is the tensions between these things. And of course, it lays down 10 broad principles, which I'm not going into now. Now, it stresses the objectives as 5 main areas. Significant improvement in health status, not surprising, but it talks of policy in all actions and action by public health sector, then progress towards universal health coverage. So this is when people say, does India have a roadmap for reaching universal health care? Yes, it has, formally stated. And it talks of 3 major issues: free comprehensive primary healthcare services, which are largely public provided, and informed access and affordability and quality of secondary and tertiary care through public hospitals and strategic purchasing, which implies a mix of providers and significant reduction of out-of-pocket expenditure. It then talks of reinforcing trust in public health systems and this particular term, alignment of the private health sector with public sector goals. And there's a question of how alignment is achieved, because alignment is not only regulation, alignment is also monetary incentives, etc. And the specific, then there is a specific quantitative goals and objectives, which are introduced later. Now, the policy thrust, adequate investment. So let us take the first policy thrust. What is the baseline when we are writing the policy document? It's 1.04% of the GDP. There's another figure goes around 0.9% of the GDP. Important to keep track of both, which is less than 4% of total government expenditure, about 30% of total health spending, and about 957 per capita. And the central government share of this is about 0.34% or rupees 325. And what the policy does is declare a target of 2.5% of GDP by 2025. We are at 2025. And therefore, it's a very good time to look back on that. It also makes a very good commitment of general taxes as a main source, but health says also to be considered and to leverage corporate social responsibility towards this. Now, where are we 8 years later? And you have this Press Information Bureau release of January 2025 that I quote the first 2 lines from. But they relate to 2022 figures. There's always a gap before you can assemble those figures. And the total health expenditure is 9.04 lakh crores, which is 3.8% of the GDP. That's total expenditure, which is 6,600 rupees per capita, of which 12.7 is capital expenditure and 87.3 is revenue. The public health expenditure increases to 48% of the total health expenditure, and by PIB, it's 1.9% of the total health expenditure, or rupees 3,168 per capita. But if we estimate in a slightly different way, using a more modest and things like keeping water and sanitation and ICDS, etc., not out of the calculation. Comparably, you can say it is about 1.6% of the GDP, which means it is about 0.6% is the center of the GDP is central share and 1% is the state share. meaning the center is about 40% is this. Is this good? Really not very good, because we are starting with a very weak baseline and our ambition is also very weak. 2.5% places us already below the overall average which most countries work on. So given the fact that our baselines were weak and our ambitions were weak, our rank as proportion of total health, public health expenditure as a rank of the total health expenditure is now 179th rank out of 189 countries studied. I've given the sources on some of these, but these are not the only sources. There are many sources. This is just for you to have a look at it. And some are trying to get a more recent source on this so that you have a recent period. So here is the first major issue. In absolute terms, as your GDP rises, the money available for healthcare increases. As a proportion, it has increased marginally. But remember, the costs of healthcare are also increasing. So one is not very sure whether in real terms it has actually improved or not. I mean, not only talking of inflation, but talking of what it can buy. We are not at all sure of that. But there is no absolute figure that can actually tell us this. And anyway, our figure is 2 to 3 years old, and there are some concerns about this figure also. So much for that. Internally, very often you will find government officers talking about their difficulty in spending the money also. So I'm not going to overplay that. But I think this important point to understand is that we are still, and our primary problem remains, an underfunded public health system. The second policy thrust, and this page is a quotation from the National Health Policy, is about what is called the Swasth Nagrik Abhiyan, and it talks of really the other sectors in health. I'm sure your public health teaching has emphasized this, that only about 30% of health outcomes can be attributed to health systems and healthcare delivery. A lot of it depends upon the social determinants, on inequalities, on poverty, on hunger, on air pollution, on different things. And in a recognition of this, there is much that individuals and families can do to prevent disease and promote good health at their individual levels. But if the social and economic environment in which they exist, where they work, live, and play, where they bring up their families, interact with the community, and experience life, is not conducive to good health, the impact of individual behaviors may be severely limited. It's a statement that you can make proud of a public health thing, because it actually captures this in the same spirit that the Bore Committee's preamble has captured it. And then, because at that time the government was gaga about the Swachh Bharat Abhiyan, the policy drafters decided to ride on that thing by creating many more three-word slogans, because our government likes a certain type of packaging. So we called it the Nasha Mukti Abhiyan, the Yatri Suksha Abhiyan, the Nirbhaya Nari Abhiyan, and then to balance it all, the Swasth Nagrik Abhiyan. So I used to think that actually the Swasth Nagrik Abhiyan has sunk without a trace. But guess what? When my surprise, if you look at the annual report of the Ministry of Health and Family Welfare, there are full 10 pages devoted to the Swasth Nagrik Abhiyan. And so you actually see that it has the role of VHNCs. It has got a bit equated with behavior change communication and what the health department does. IEC, they call it IEC, and it what the hell, which is better than nothing, and we should therefore be thankful that this much is happening. But it does not, for example, take very into what other departments do, which, if you know the nature of government, in practice is very difficult. No secretary listens to any other secretary very easily at the ministry at this level, and ministers are even more difficult. In fact, some ministers can deal, but there has to be conscious things. But you can't say nothing is happening in road and railway safety or in occupational health or air pollution. But we do know that some of these social determinants have actually deteriorated. I think that we need to really therefore be a bit worried about this. There is a number of other activities which are also mentioned, and some of them have changed, like zoonosis. Now it's the One Health approach. It is not there in that document. One Health approach had not come of age. That came after the pandemic treaty. And now we would say this. And occupational health is sort of missed. The school health program exists as the RBSK fairly well, whereas yoga and Ayush has really taken off. They talk of 4.4 crore wellness camps, etc. So there are some things that, this is what I mean, the problem of amplification and attenuation of the different lines of a policy. Some lines have got attenuated and some have got amplified. Now come to the organization of health services, and this is where I shall spend another 10 minutes, and before the rest of it we can actually wind up for you to look at. The policy specifically, the first slide of the topic is always a quote. This is something which it talks of 7 policy shifts. 1, primary care, and it says we shift from highly selected and fragmented to comprehensive and continuous. 2nd, secondary care, input-based to strategic purchasing from a mix of providers. 3rd, public hospitals, from cost recovery approach to prepaid, therefore free care in that implied, but prepaid has its meaning and we'll come back to that. Infrastructure and human resources, from normative and targeted approaches to addressing shortages, urban health to scale up, national health programs to integrate, and Ayush services for developing it further. But the first 4 were actually much more the active point. Some of it is also about politically correct. Ayush services has since become a separate department and ministry. Okay, so this was written at that time, and now they would have their own policy statement also. Now, the first of this is actually what is the big leap forward. This is the comprehensive primary health care. The policy talks of delivery through a network of health and wellness centers. It's comprehensive. It covers all chronic illness. And important, it stresses in the document itself an entitlement approach where every family has a health card denoting entitlements, including an annual checkup. The use of ICT tools, including telemedicine for continuity of care, and a system of incentives. So there is a vision of how we will reach from selective healthcare that determined our 90s. And even under NHM, there was no real shift from selective healthcare, because in parallel to NHM, we had the RCH2 and we had the vertical TB and HIV programs. They were all verticals. So it was still a selective approach, and this mainstreaming of NCDs into primary care is a significant 2017 national health policy shift. And this, I think, is something that we really admitted. So it's a major leap forward. Just look at the numbers. The program was, in fact, the operationalization, the task force was set up in 2015 itself. The policy, we had a consensus on this. The debate was on the rest of the policy. So the ministry said, why should we wait for the rest of the policy? Let's set up an operational task force. And I had the privilege of leading this task force. And that report is something that you public health scholars should refer to. It's still a report of how we arrived at this policy, the inquiries, the case studies, the consultations, etc. But this is operationalizing the fundamental principles. It was then rolled out in 2018 with target set for December 2022. Now, that was a bit incredible to achieve it. But this government has its own logic, and they love these targets. And surprisingly, in this particular area, to my own surprise, they worked. To what level of content and thing is an issue. But today we have 1,75,560 health and wellness centers, of which 1,47,000 are upgraded sub-centers, of which 1,38,000 have an entirely new cadre called the mid-level healthcare provider or a community health officer in post. And the rest are primary health centers renamed with more depth in them, 28,000. This is a singular achievement. If you know the previous period, subcenters were rather rundown places with more as a standpoint for giving outreach services, more as a touch point, you touch and go sort of thing, rather than anything happening within the subcenter. Now the subcenter is transformed. I was just back from Meghalaya 2 days back. Even in the remote area like West Jayantia Hills or the Garo Hills, you find a fairly sized building, you find 4 health workers, you find an agenda, you find a number of activities happening. There has been a transformation of the health subcenters, which effectively means that the peripheral facility from 1 in 30,000 has dropped to 1 in 5,000 to 3,000. This is really a huge transformation. And it has been supported by what is called the ABHIM, the Ayushman Bharat Health Infrastructure Mission, which means that you have money for building all these subcenter buildings. And therefore, this is, I think, one of the major leaps forward. However, and in some sense, we need to be very careful. The content of the program still struggles because there are many barriers. So most HWCs cannot provide full range of services. Of course, the government's PIB note claims that 1,37,000 has achieved it, but that is what governments do. So I think we should take that in our stride. We're particularly weak with respect to non-communicable diseases and mental health. Everybody swears by mental health as being important. So if your students are coming back and telling you mental health is important and being neglected, oh, come off it. We've been saying that for 15 years. The question is how? And even after health and wellness centers, we are struggling with this concept. There is a team in place, but seldom is the team fully in place. And even rarely is it acting as a team. So you have an MLHP, he's doing his own thing. You have 1 or 2 ANMs, they are doing their own thing. You have a male worker, they are doing their own thing. And there are 7 or 8 ASHAs who don't get linked up into the team. So the lack of a team, that each one of them is funded by a different channel, supported by a different channel, is one reason why the vision of the policy doesn't come through, because on an operational level, the team is everything. And screening becomes an end in itself, okay? And no continuity of care across levels of care, very poor specialist backup and referrals. Community engagement is poor. But if you say primary healthcare has collapsed like many people do, that's totally wrong. I think at some point it's definitely improved, even though at some of the places, the transformation of health and wellness center is cosmetic, in that the building is there, the people are there, but the functions are still lagging behind. But the core functions of selective healthcare earlier have improved, and there is also many things to do. I think we will come back to this later on this, but maybe I should have. Oh, here, I missed this particular thing. There is a line over here. So there is the consultations. We are talking of 300, and this is government data, the 372 crore consultations. Crore. That is 2.5 visits per capita of the population. And many don't visit health and wellness centers. That's still an awful lot, over 4 to 5 years. 100 crore people screened for hypertension, diabetes, 89 crore screened. And this is the screening thing. Yoga sessions, about 5 crore sessions held. Now, there's a liberal hype in this, and in India, any number is very large. So if you go without a denominator, then you are going to be terribly long. And if you say 100 crore hypertension screen, they have no system. If one person is a bit possessive and comes 12 every month for screening, you will still count him as 12% screen. So that is changing now. In fact, recently you can't do that. But there are many ways in which these figures will misconceive. But I think you should know what the government says before we begin a critique on that. And that's why I say that when you actually see the real problem with screening, I'm just bringing out a piece on breast cancer. So many people, they say, have screened for breast cancer. But only a small fraction of people suspected of breast cancer can be initiated on the appropriate treatment within 8 weeks. The whole purpose of screening for breast cancer is lost if you cannot offer confirmation and treatment within 8 weeks. And that is not even mentioned in the whole write-up about it. And that's worrying. If it is mentioned and you say this is the gap, and I know, for example, in JIPMA, where I work, you have more than 350 patients every week. There are 50 new cases coming in. And each patient comes in, requires 1 year of intensive treatment, 5 years of treatment. They just can't cope with even 30% of people being screened. Pondicherry is one of the better performing areas. Even with 30% of being, they cannot cope with the breast cancers that are there. So the problem of many of these screenings is the rest of the system really able to cope on that? And I think, therefore, there is many challenges to go. But coping requires your secondary and tertiary care centers to come into basis. And that's why we look at this whole thing of the policy shift. Now, what did the National Health Policy have to say about secondary and tertiary care? This is what it said. Strategic purchasing refers to the government acting as a single payer. Well, that's a very ambitious statement. But that's there in the National Health Policy. And the order of preference for strategic purchase should be public sector hospitals, followed by not-for-profit hospitals, and then commercial private sector in underserved areas based on availability of services acceptable and a defined quality criteria. In the long run, policy envisages to have fully equipped and functioned public health hospitals in these areas to meet the secondary and tertiary healthcare needs of the population. Public facilities would remain the focal point in the healthcare delivery system, and services in the public facilities would be expanded. This is in para 3.3. This is architecture 1. But then you go down to para 13 and it's saying a different thing is in the same policy. And you can actually see this is the sort of dialogue. The contradictions within a policy document are reflective of real life contestations. They are not mistakes. They are not that somebody didn't know reading or somebody was lazy, but they are actually the standoff points. Both positions stood their ground and eventually this was allowed. But the contestation plays out in implementation. But the contestation is reflected here. So here that says the policy advocates a positive and proactive engagement with the private sector for critical gap filling towards achieving national goals. Remember, para 3 also said critical gap filling. So they are not totally contradictory. One form is through engagement in public goods where the private sector contributes, the other private sector to engage to invest. That is on commercial terms, which may entail contracting, strategic purchasing, etc. And strategic purchasing should play a stewardship role in directing private investment towards those areas and those services where there are no providers. And it then says the main mechanisms of strategic purchasing are insurance and through trust, supplemented by public-private partnerships. Actually, it doesn't talk of public-private partnerships. I added it here just before your presentation over here, because in some sense it is implicit over there. When you talk of purchasing, you can do it through this. So this is the whole sort of contestation. It's an ongoing contestation and we don't know. Now look at what is publicly funded health insurance. Today, formally eligible for coverage is 69 crores out of our 135 crores. Look at the first column. Okay, 69 crores out of 135 crores. Then come down social health insurance, of which employees state insurance is the bigger, is 13.6 crores. And then private voluntary insurance is 11.5 crores. So the uncovered population is 30% of the population, right? According to this statistic of National Health Authority, 70% are eligible for coverage by insurance, which is not the same thing as saying covered by insurance. And this they make clear in the next one when they say that out of the 49 crore eligible individuals, 10.35 have been issued e-cards, and those eligible for ABPMJY 5.5 cards. Now, you are looking at two things here. Under government subsidized scheme, there is a state extension scheme, and there is without state extension. Meaning there is something that the central government pays for, which is presumably the bottom 40% of the population, but actually it is limited to those who come under the SACC census. And then there are the state programs. So if you're looking at Maharashtra, the Maharashtra state has an insurance program, which is merged with this program. And one part of the financing comes from the center and one part, and there is a formula that works it out. So if you look at it together, it is 51%. And out of this 51, 49 plus 20 crores, 69 crores, what you have is about a 15, 16 crores. It's a fairly honest statement that they have made over here. And that is quite reflected and inconsistent with the studies that have happened. But these coverages are coming up and they are increasing covered thing. So the features are the bottom 40%. Some assured 5 lakhs per family, some say 25 lakh, etc. That some states, forget about it. Very few people come there. Then that's a different discussion. Secondary and tertiary care hospitalization. No state except Meghalaya covers for outpatient care. The process is cashless, paperless, Aadhaar authenticated. Center supports 10 crore families in 33 states. And the achievements, again, there are these big numbers that are very typical of India. Oh, so many crores, so many crores, so many crores. So we will really look at that. And so many public hospitals, private hospitals, this is a fraction of private hospitals. Public hospitals, almost everything is empaneled. But private hospitals, this is about 1/5. And 13.74 lakh beds, so many specialists, so many procedures, so many incentives. That's the way you look at it. Now, look at this. There are 3 ways in which they are covered. One is called the trust mode, and one is called the insurance mode, and one is the hybrid. Insurance company, the government actually tenders and recruits an insurance company and gives the insurance company a premium for every card they make. And those are the people covered. Whereas trust, the government is doing the purchasing directly without intermediation of an insurance company. So one of the big debates has been, which is better, trust or insurance? The simple truth is almost everybody started as insurance and then became a trust. Very few started as a trust. And therefore, what you are seeing, even say Kerala, for example, they had hired insurance company, Reliance, for their insurance agent. There was a huge outcry against denials by the insurance company. There were allegations the insurance company was making money, and then they shifted it to trust mode. So you have one important mode of implementation, beneficiary database. These things are features of it. There is another dimension. Some states say that we are not covering 70%, we are covering 100% or 95 plus 90%. Those are those marked in green. Some have a step gone beyond the thing. So this is NFSA, if you guess it, points to you. It is a great one in these acronyms. It is National Food Security Act. What is that sitting here and doing? Meaning it has been extended to all those with a ration card. Okay, that is 70 to 90%. You'd never guess it from the acronym. Okay, and then SECC is the socio-economic census survey of 2012, which gave a certain number of the poor in each state. That number is fixed, and the states can play around within that number and get that thing. So there is some beyond SEC numbers and some SECC only are covered. So you can really see that so the important point is that we have got a large number of states where you have universal coverage. And if you take along with it, so primary care and secondary care, we are in the dangerous situation where we have achieved universal health coverage, but we are very miles to go to achieve universal health care. And this dialogue of what is the gap between coverage and care, becomes where you arrive in when you enter your public health course and you are doing a public health thing. You are coming to a situation not of achieving coverage, but this is the actual coverage. And these are government figures. I mean, some of these are there. So a lot of my interest has gone in it, and I am not going to be able to go through all of this. These are three of our papers on this, our group. When these are the latest one is just 1 month back, May 2025, effectiveness of PHSI schemes, insights from the household consumption expenditure survey. And then we had the earliest of these effectiveness of that was my student's MPhil thesis. And then there have been in between. And these are just my papers or papers on this. The number of papers on this are 100 plus. Okay. So I think this is well-studied area. And if you look at the overall area, these are all a number of papers. You should actually visit the website that I use, the Right to Healthcare, RTC resources.in, where you will rthresources.in, where you will actually see many of these, and you can actually see what of this. So this is an area where we really are doing things. Now, let me just say the latest survey, 2023, 8 years stock taking. You're in for a surprise. The household coverage is not unreal. It matches the government's realistic claims. The hype that comes in the press release may not be matched, but if you look at the government document seriously, the government knows, and it's rather correct. And I am told that the next year's survey, 2024, even this has improved. But the percentage of hospitalization in enrolled hospitals using PHFI benefits is low, meaning when they are utilized, only 1 in 3 utilized. And of all hospitalizations, if you see, the coverage is 9.39%. So what I'm saying is, I have a card and I needed a hospitalization. And the hospitalization, they swiped the card, so I know that it was used. And I feel only 1/3 of the people were actually offered. But even more worrying is that if you look at enrolled and not enrolled, paradoxically, we are seeing as a group average, you are seeing out-of-pocket expenditures are actually higher in those insured. And that is a really problematic, because that really, the whole idea of financial protection becomes under threat. And we need to understand this. And this paper actually discusses this problem in some detail. And this is a very recent paper, just 2 months back. Now, this whole thing is changing. It's changing dramatically. Policies are dynamic documents. So the document is changing. So we are moving from hired insurance agencies to government itself acting as trust. Select insurances, there are more and more private providers are exiting. They say the costs of reimbursement are too low. And the public, there is also a reservation of more and more procedures to the public providers, especially, for example, vaginal hysterectomies, for example. You are finding a huge number of abuse. I thought I understood the case with everything. I now found in one place knee replacement surgeries, starting knee replacement at the age of 50, a huge number of knee replacements taking place. And at that point, you actually decide that to avoid what are called the moral hazards of insurance, more and more of these start getting reserved. This is not something that policy spoke of. But at some point, policy did mention that our priority should be public sector. The scheme started with para 13 understanding, and it has increasingly pushed to the understanding that para 3.3 has. Now, why is there such a low and incomplete utilization? First thing, financing is a financing problem. It doesn't solve the access problem. So there is no card, or card is not used. Quite a lot of people, most places where they go, the services are not part of the package. All this 1,900 is because you disaggregate so many services. Many services are not. Locating a provider who is empaneled and will offer the services is a non-trivial problem. Most people go at the time when they are sick. They can't be going around chasing out, finding out the answer from the insurances. It's all there on the website. But I try to find it on the website, I find it difficult. So my rural poor who is sick and running to a hospital, to find a website is very difficult, and there is no helpline available for this. Some have now got helplines going. Public provider denial, rationing of care in some way, because they are already flooded. And private provider denial despite services being available and patient having the card. Maybe only 1 in 10 will get in the private provider because they say they make a loss if they give more, which is not really true, but they have a lot of prices foregone. Insurance denial, because the insurance has some, if you have delayed by 48 hours, if your claims pay, some procedural lapses there, you can deny. And finally, the problem of double billing, where the provider bills both the government and the patient. All of this combined to reduce denial of care. Then there are budget inflexibilities. The top one is from Tamil Nadu, a quotation on that, where actually, because the insurance company has been given a budget, it is sort of obliged to keep the number of claims it sanctions within that budget. And the budget is very low. The old problem coming back in a new way. It doesn't help if you change to insurance unless you are in a position to reimburse all claims. Otherwise, the same problem comes. Very selective coverage, supply side inequities. So you will see in one district, it is all cataracts. In another district, it is all cardiac surgery. In the third district, orthopedic surgery dominates. Very often, it is more defined by the suppliers who are active than the epidemiological issue of this. And then the insurance provider interface, the delays in payment, the barriers, and finally, last but not the least, the package rates. Now, this is something between marginal cost, opportunity cost, and prices foregone on market costs. And these are very different considerations. I'm not going into that, but this remains for, if you ask the private provider, he has one answer. The rates you give is not affordable for me. And the NHA has looked into it, and now they have what is called HBP 2.2. So it is Health Benefit Package 2.2. The rates are revised. They are opportunity cost rate. They pay even for the infrastructure. Private sector is not cheaper, costlier than public, or public sector is not cheaper than private sector, because in private sector, everybody but the doctor is paid less than in the public sector. And the doctor never truly reveals his income, so you can't actually blame that also. So there's a whole lot of issues on that. So what advantage for public hospitals? Is it a correct way of funding public hospitals? A lot of the funding for public hospitals has started flowing through the insurance route. That is why a number of countries keep to it, because it's a one way of getting into public funds. And then you find that there is a number of issues. It's an ongoing debate. There are commercial behaviors. You're converting public hospitals to behave with the private biases is one issue. Exclusions start happening, etc. But on the other way, there is an advantage in getting very flexible and responsive funding. Funding that is responsive to the requirements. So that issues is there. And then I have a number of way forward on which you will need to build on it. I'm going to go through this. But all that I am going to say in this is, I don't think we should lose, despite all the problems, lose the understanding of where we are going. This combination we see in the national health policy of universal coverage through health and wellness centers. Now Arogya, what is it? Arogya Mandirs. Ayushman Arogya Mandirs. This Ayushman Arogya Mandirs and this PMJAY and its state complements is actually a roadmap to universal health coverage. So I don't think that we need to actually ignore this. But the lesson from other countries is that the dominance still needs to be with the public provider. If we are talking of health rights, the rights are unenforceable in the private sector. I may have a card, I may go there, at best I will be breaking a contractual obligation. There is no inherent right with a private provider that I must treat everybody who comes to me. But that can be enforced as a right only in a public provider. And therefore, I think there's a lot to learn. Now, moving on, the National Health Policy also has a lot to say on human resources for health, where movement has been mixed. It talks about how to encourage how professional and technical education, about boundaries, about pedagogy. These are the areas that need to do to generate the right mix of skills in the right place. So this is a very interesting section. And you can see that there has been a lot of movement, like mid-level service providers, zero at the time the policy was passed, not zero, about 100, 200, now 140,000. Nursing education has hugely improved. ASHAs is 1 million plus. Many states are playing with public health management cadre. Medical education has been brought under a National Medical Commission, and there are measures going on this. So you have seen a number of areas in which human resources have moved. Engaging the private sector is be a mixed bag. For whatever reason, the National Health Policy did not emphasize regulation. It mentioned it, but did not emphasize it. And part of the reason was the pushback. There was the worry that if you actually push that too strongly, then the whole policy will get questioned. Like what happened in Rajasthan, when you tried to make the obligation onto the private sector, the whole right to health care law itself started getting threatened. And therefore, there was a tactical decision not to push it. But it still means that you can alter behavior through positive measures like purchasing arrangements, non-financial forms of engagement, partial roles, etc. And some of these have developed. Finally, one important dimension was the legislation for health and right to health. If I must say what the National Health Policy 2017 did, it kicked the can down the road. It very strategically said, didn't say yes, didn't say no. It said, let's consider it down the line. But it also raised in the draft certain central questions about an act. Is it a model act? Can the central government legislate for the states? Or can we make like the Clinical Establishment Act, an optional act? What should be the nature of the act with relation to the Constitution? Should it cover only healthcare or social determinants also? And we were of the view that the Public Health Act should cover the latter. And the financial viability and implementation feasibility of a law. And really, what is the health rights architecture? What does it mean? But in the intervening 8 years, only one state has moved in this direction and not at all successfully on that. So this remains an open question. And at some point, I think this remains one of the key problems of health policy. Remember that our health policy comes under the International Covenant of Social, Economic, and Cultural Rights, which has a right to health is an obligation. Under that act and its elaboration in General Comment 14, we are supposed to bring out periodic policies to show that we are on a pathway of progressive universalization to the achievement of the law. And therefore, the law has to show the policies have to show that we are marching towards achievement of right to health. And therefore, this policy does show it, but you can see that we haven't moved very far about it. So, if I must summarize, there is insufficient increase in health budgets. There's a growing corporate, commercial, private sector without regulation on which we are silent. There's a limited increase in human resources. I think there's more in the public sector. There's a cloud of uncertainty around the National Health Mission. But on the positive side, the Ayushman Bharats have created a great rise of expectation. And we have the health and wellness centers, the PMJAY, the health infrastructure mission, and I don't have the time to go into it, the Ayushman Bharat digital mission and the health information architecture. And this AB is, I'm just flagging it, it's non-serious health camps, which is also there in the declaration somewhere, but not much available. But basically, therefore, in some of these areas, there has been progress. And there are reasons for hope. Policy is dynamic. It is constantly being molded, even in the process of implementation. All stakeholders matter, but some matter more. The private sector has its own say. in being able to shape the policy. Evidence is the power that the weak bring to the negotiation table. So if you're really interested on the interests of the poor, and go back to the great father of public medicine, social medicine, and work of the same father of pathology, they talk of physicians as being the natural attorneys of the poor. Physicians can't play the role, but public health professionals must play the role. Because in these stakeholder meetings, you have the industry there, you have the government there, you have the bureaucrats there, you have the politicians there, you have the educators there. You have even the affluent and elite there, but who speaks for the poor? Even by definition, there is really nobody there who can articulate the requirements of the poor. And that, I think, is the task of the public health profession. I think that is our duty fails if we fail to act as the natural attorneys of the poor. That was the vision of the whole science when it first developed. Thank you.
Thank you. Thank you so much, Professor Sundaraman, for that rich and wide-ranging presentation. I think it was not just a evaluation of the national health policy, but your talk actually helped us to reflect on the broader landscape of Indian public health system, I think. So now we will move into the question answer session. I request participants to unmute yourself and ask the questions, or you can also post your questions into the chat box.
Okay, so can I go first?
Yeah, sure, please.
Okay, hello. My name is Anisha. I'm a PhD scholar and I'm working on social demography and health. I'm working in ISA Pune. So my question is, first of all, a very enlarging presentation, because before this, I have only heard about these policies in my health policy class. So it was very learnful in that way. So my question is, as you did mention about the social determinants of health. So when we try to look at a certain kind of a disease, suppose we have disease from AIDS to mental health, which also has a certain social stigma associated to it apart from the disease. So do you think of is our policy shooting towards that part where we do need multi-sectoral collaboration, maybe of the communities, of the grassroots organization and other actors like institution, to also reduce the stigma part, because it does lead to problem for the person who's getting the disease and getting the diagnostic, the screening, and also for the disease. So can you look for policies that do actually look at that part as well?
Yeah, that's a very important point. And one of these gray areas of the policy, I don't think the policy said enough about the community engagement and the issue of the subjective side of health behaviors and of stigma, taboos. There is something mentioned in the policy thrust when health in all segment. There is passing mention of it. But I think that there's so much the policy does not do. One has to fill the gaps. What the point you raise is important, but I don't think that stigma was really, it does get reflected in one or two paragraphs, but I don't think it has achieved in terms of many of the determinants of health seeking and the discrimination and exclusions due to stigma. Those sort of things have not really come in. So the behavioral aspects are very underplayed in the policy document. That's where it is. I mean, which doesn't prevent us from doing so. And at some point, we do need to engage with this. That's very correct. But that's...
Okay. Thank you, sir.
I think before others ask the question,
Yeah, hello.
Yeah, please.
So, very nice session. It's really emphasizing on public policy, MDG, SDG, then health, NFSA data and everything. So it's very conceptual framework and how policy can be linked with the implementation of the programs at the last mile. So it's a wonderful session and very depth knowledge it has been seen in your presentation, sir. And I just request it would be possible if you can share your presentation. So thank you. Thank you,
I
sir.
have promised to share that. I'll be circulating it immediately after the meeting.
Okay, thank you so much, sir. Thank you.
And you are free to use it, preferably with acknowledgement, but without it also. There's nothing very unique.
Yeah, mostly what happened is,
So many people who have said that, please feel free to. Yeah.
thank you.
Yes, I think a lot of inside data and informations are there in the presentations. So definitely will be sharing. Yeah, MD Bakar, would you like to ask a question? I can see your hand raised.
Thank you very much, sir. It was very wonderful and enriching experience with you for the last one and a half hour. Sir, I am a recent graduate of public health from Ajim Premji University in Bhopal. And I just want to understand, yes, our country is very diverse in nature, be it geography or other social determinants we talk about. Sir, how this policy tries to include diversity in the sense, except making some changes in population basis, some like that, means how we are incorporating the diversity.
So I think the issue is really at some point the stress on equity and the question of not leaving someone behind. So there is a clarity that the primary healthcare approach is necessarily an approach that goes close to community and the extra emphasis that is needed to reach underserviced communities. That's where it stays. And across the board, the affirmative action that is required, it does have a section on that. But basically, it comes in the way of doing it. So inequities can be by geography, it can be by social status, it can be by occupation. And at some point, one has to actually look at how each one of this. So there is some way of preventing exclusion, but there is also affirmative action required. So for example, in remote and rural areas, how do you incentivize professionals to work there? How do you solve the problem of lack of human resources? This is now an old question. This is not a question where it should be asked rhetorically. It's a question which has admitted of answers across different countries and societies. And therefore, we should really look at how we can actually, where they have done so, and it may be monetary incentives, it may be educational formats like getting a new type of professional or bringing people from those areas and allowing them to access education. And there are ways in which you can come across many of these issues. So I think the area of addressing when it comes to diversity, when it comes to behavior change, etc., behaviors diversity has an important role to play in how you message. I think that I think is a very important thing that you should you should consider. The messaging you have to start with people's level of knowledge and be able to achieve that and prevent exclusions. But there is not so much, there is some differences in the epidemiology. Okay, so you may have sickle cell high in one place, you may have thalassemia high in one place, but those are not the issues of diversity, or those are the more easily handled issues of diversity. The difficult issues to handle in diversity relate to inequalities.
Yes, there is one question in the chat box. I'll read it out for you. It's considering the morbidity and health expenditure due to NC days, according to you, where the next NHP should focus in this area?
So At this point, even this NHP is focused on NCDs. In its comprehensive nature, since RCH and selective is already covered, the notion of comprehensive is notion of NCDs. But NCDs should not be limited to hypertension, diabetes, cancer, and this. NCDs is everything else that is. By definition, anything not infectious, when a disease is an important issue. I think, therefore, it is but it is lies in this axis: primary care, tertiary care, and the continuity between these two levels. A lot is lost in the continuity between levels. What do I mean? I mean, you may do screening for breast cancer, but then somebody must follow it up and start the treatment and then send them back for continuing medication and for follow-up. You may start a diabetic, but continuous care, treatment for ulcers, so many things will have. It requires coordination across levels. So the challenge in NCD is getting a systems approach to a patient-centered care. It's not that NCD is yes or no. The problem is to get a care mechanism. Suppose I have NCD available in the medical college hospital. It's always been available. A whole lot of the crowding in the medical college hospital is because even for hypertension and diabetes checkup, they have to come all the way there for the poor person, which is a waste, which is really wrong. At some point, therefore, it is a question of being able to move this down to that level.
Okay, yeah, one more question from Kushbu is that are there any key observation and issues in the studies focused on NHP 2017 and its implementation with respect to older person and geriatric care?
I'm not very conversant with all of it, remember? So is there a recent study on it? You are the better people to tell us. Because you follow the studies, I follow the field. I've been visiting, I spent a lot of time. Last 4 days I was in West NPILs. I spent a lot of time in that, and then so I really wouldn't know. But there is this longitudinal aging studies of India, the LASI study that has come out. I haven't had occasion to look at it, but I don't think it is after the policy, before the policy. But I think you should look at LASI studies and elderly care. I keep seeing thing, but I don't see it related to policy. No, the policy itself is rather light on. It doesn't have a real section on elderly care. It mentions it, flags it, but it doesn't really engage with that. Because you see, we are in a situation where we are moving to include NCDs for the first time. So our priority was that. And now the elderly care, if you write an NHP, next one, definitely elderly care will be a full section on something like that will be there. So that I think is an important. Yeah.
Yeah. Another question is a very lengthy question. It's about the paradox of higher out-of-pocket expenditure for enrolled individuals as per the household consumption and expenditure survey. So the question is connecting with the health behavior. Is it kind of because of the behavior of people?
So the issue is that these surveys they describe what has happened. They seldom answer why it has happened. Okay, that's a problem with cross-sectional surveys. You require to be backed up by different things. In our article, we have speculated on what has happened using other references. And now one has to actually see that what really happens. There is a possibility that there are a mix of patients, the sort of diseases for which people have taken insurance, for which they were able to use, were of a more complex nature. Okay, so when you're doing hospitalizations, we know, for example, that most CMCH, the PA publicly funded health reimbursements go to, for example, cardiovascular disease, bypass surgeries, stenting. So these are places where expenditure will be more and out-of-pocket expenditure is still more. But it does worry us that what you have is that, we know from other studies that in effect, what you get is something like a discount and not true cashless service. When you go closer, you find that there are some people, less than 1/3, who do get close to cashless service. But at the other end, there are so many people who have such a high out-of-pocket expenditure that your averages tend to be bad. So, and in these studies, we are averaging most of the time. So aggregate averages will, I think, maybe we should look at what proportion got less on this. So I think there's a scope to look at it. But these surveys are not designed for looking at that. So that's...
Yes, right. The other question is with respect to preventive and promotive healthcare. It's from Seal. Seal Parik is asking, right now PMJY mainly covers hospital treatment. Do you think it can go into a scheme that also support more regular everyday healthcare like health checkups, prevention?
So long back when I was in Bombay, I was in a meeting with insurance companies. And they said, please, no. I mean, they were so frightened. If something has saved us from that, it is the insurance companies themselves. They say, we are having such a big problem with things like knee replacements. There are fraudulent things in appendicectomy. Can you imagine us managing reimbursements for preventive and promotive care? It's really, see, insurance, the word itself has a certain meaning. There has to be risk. A risk that is shared by everybody, and the adverse event should be rare, and everybody should be contributing to the risk pool so that somebody will be ill, but most of the people would have contributed to the pool. When it comes to preventive and promotive care, everyone needs that care. By definition, everyone needs that care. So you can say, can they purchase that care? But you can't say, can I be insured for that care? Insurance comes only when there is an issue of risk. So even for pregnancy, you can't insure for pregnancy. You can insure for risk in pregnancy. But the point about it is wellness conditions, health promotion conditions required. And that is also the flip side of insurance problem. The flip side is your attention so much goes to the cure that nobody attends to the preventive and promotive care. And that becomes a public health function. That is why, quite correctly, our architecture has been to keep preventive primary care out of insurance more. Because primary care, even when I treat a diabetes under primary care, my treatment of a diabetes is directed towards preventing renal failure and strokes and heart attacks. It's not just treating diabetes. So that whereas in the private sector, my gain becomes a whole lot of just curative. I'm paid for the curative care, not for what I prevented from happening. So that becomes an interesting way. And therefore, I think preventive and promotive care will remain a public good, a merit good, if you want to be very correct, public good, which is paid for preferably by the state or purchased on your behalf by the state. It can't be in an insurance.
Yes, right. I think, yeah, as you said, the definition of insurance is coming from that risk. Any more questions? I would like to, yes. Any questions?
Yeah. Can I go next?
Yeah, please. Yeah.
Yeah. So thank you, Professor, for your presentation. Really enjoyed listening to that. My question is related to, because you mentioned in the beginning that you were involved in drafting process and policy making. And towards the end, you mentioned about, means no one can deny that health services are merit good and the state should be promoting its consumption. So my question or point is related to this thing. Towards the end, you agreed that there is no voice for the poor in policy making. So if I say that politicians not necessarily voice the concerns or needs of the poor, I think perhaps you will support this statement. Yeah. So thank you for your response. The second point is that there is an argument for promoting private sector. But in your presentation, I found that private consumption of health services also lead to unnecessary consumption, misdiagnosis, and these are the things which have been debated since long, when the question of in-kind versus in-cash transfer or insurance-based mechanism have been discussed or designed. So there is a case to argue that health services are merit good, and there are these instances and evidence which has led to unnecessary consumption of health services, and the burden falls disproportionately on the poor. And therefore, why we should promote privatization of health services? If this argument is made and you were present in that meeting, then what would be the response? Thank you.
Sir, you need to unmute yourself.
I think,
Yeah. As far
Yes.
as policy goes, it doesn't give a call for privatization. We do have in the last 1 year, especially, a lot of bids coming in to place district hospitals and medical colleges to private sector in different states. But that is happening sort of without and beyond the policy. And at some point, there is a pressure, and that is an issue on that. And one has to wonder about why it happens. There are many reasons why this particular thing is a trend that we see. But there is also a countervailing trend on that. I mean, most people who have worked within the government were surprised that this government did not more aggressively privatize. But the issue is that for most of the poor, for most of the people, majority, I would say as much as 90% of the people, you really are not in a situation to let markets be the basis on which they can access care. You do need public provisioning of one means or the other. You do need that. The problem has been that public provisioning is defunded. It is inadequate in size. Access and quality are the problems. So there are problems that you need to solve in public hospitals to make them much better function. That being said, privatization is not the answer. In fact, it is part of the problem.
Yes.
Thank you.
Yeah, sir, I would like to, kind of to come back to some of your points. Uh, for example, the mismatch in the universal coverage and care, the behavioral change communication, and IEC taking up a huge portion of the budget. Then the still within the selective primary health care. So is it because the policies is kind of still keeping the responsibility with within the in the hands of the individual, or the state is ready to take the responsibility, or is it like no one is taking the responsibility of the primary healthcare, or is that the problem with the responsibility, which is not clearly defined in the public health policy?
Well, you said many things that go in many directions. So let me try to get this right. So first thing is, government is not spending much on IEC. Its expenditure on IEC is miserable, and especially at the periphery, at the village, to reach the marginalized sections, it is even worse. So I think, though I found mention of it in the report, it's far from adequately represented then.
Yes, okay.
The other thing that you were saying, that what was it? You're coming to the end of the
universal coverage and care, that mismatch. Then the
Yeah, but that mismatch is something that the overall program has to actually, that's the whole challenge. At some point, how do you actually extend services? No, but there was some
Then
other.
the selective primary care, and within that.
No, there is a real inability. There are complexities in this. Huh? They are struggling at the ground to integrate vertical programs into thing. And if you bring a huge burden of apps and data work along with huge new program, you are finding it very difficult to expand the basket of care provided for many reasons. One of them is the lack of continuity and lack of specialists. The other is already that you tend to overburden by increasing the work involved in data gathering and reporting for each new disease. So there are many barriers to why we have been unable to move to comprehensive healthcare, despite a clear stated intention of doing so. Finally, when it comes to policy, there is also, you see in this period, private equity in healthcare has increased. There has been a huge increase in corporate hospitals. Now, that is a different understanding, because you must see that the Ministry of Finance and the Ministry of Department of Industrial Promotion and Policy deals a lot with the private sector. So they are forever encouraging foreign direct investment and expenditure in corporate, commercial, private sector, which draws away your staff, your senior specialists. It sets different standards, which creates a different image of healthcare. And we don't know quite much what to do about it. But finance ministries are very excited by them, because your overall growth rate, and for many of them, we want to be a 1 trillion economy, we want a high growth rate. They are interested in looking at healthcare industry as a source by which they achieve their economic growth rate targets rather than their poverty reduction targets, if I may put it like that.
Yes. It's already 4:30. Thank you, sir. Thanks for the answer. It's already 4:30. So if no more questions, maybe we'll move on. So thank you, Professor Sundaraman, for especially for engaging so generously with the questions. So now I would like to invite our Dean, School of Public Health, Professor Suma Nair, to share a few words. Ma'am, over to you.
Thank you, Nandu. Thank you, Professor Sundaraman. It was an amazing, very insightful talk, and I'm sure the students and others who logged in have really gained a lot from your extensive experience in this, realm. A very aspirational health policy, I must say, which is very comprehensive in the paper, and like you rightly said, has looked at a lot of things. But I do believe that perhaps we need to have more funding put in by the government and probably regulate the private sector. We have a very unregulated private sector, and that probably is going to increase the burden of health on the common people. And that I feel is going to be a challenge in the days to come. Like you rightly said, the FDI in healthcare is increasing the number of private hospitals, the hospital chain networks, and we're talking of huge hospital chain networks. It's great on paper, and perhaps like they want to call it $1 trillion economy, but I'm not sure if that's going to translate into the common men getting what they really need. And so that's a big challenge. And I hope we are able to navigate this in the days to come and probably make primary care and the healthcare for the common men more accessible. And by common men, I also believe that we are all common men. It's, healthcare is pretty much not affordable in the current setting. So we need to think a lot more and perhaps make this a little more affordable and accessible to everyone. Thank you so much. And we look forward to interacting more with you from the school, from other aspects as well. So thank you for all those who logged in. And thank you very much, sir, for your great inputs. Thank you.
Thank you.
Thank you so much. Thank you so
Pleasure.
much, Professor Nair. Before we formally close, I would like to take a moment to express the gratitude. So first and foremost, Professor T. Sundaraman, thank you for taking the time to be with us today. So your talk set the perfect tone for this series, and we are honored to have had your insights get this inaugural session. So we'll be having more such sessions with experts from the field. Our thanks also to the Honorable Chancellor, to Dr. Vijay D. Patil and the leadership of DY Patil University for their encouragement and support. A heartfelt thanks to our Dean, Professor Suma Nair, for supporting this event and making it happen in a short time. Thanks to Dr. Daksha Parmar and all my colleagues for this arranging this webinar series. A special thanks to Ms. Mayuri, our admin staff. And finally, to all our participants, thank you for joining us, for your thoughtful engagement, and for being part of this important conversation. So now we look forward to welcoming you again on 1 month after, exactly on 4th September 2025, we will be having another section talk by Ms. Aruna Roy on youth and participation in public policy. So with that, maybe we'll conclude today's session. Sir, would you like to say anything, or we will?
Thank you.
Okay, thank you then. Thank you, everyone.
It's a pleasure.